I'm really happy to introduce Dr. Kuba Gajewski. Have I got that right, Kuba? Thank you. Who's the Director of Research at the Royal College of Surgeons in Ireland Institute for Global Surgery. He's a health sociologist with nearly 20 years of research, teaching and project management experience in global health. He has been involved in several population-based studies, including studies of young people's well-being, diabetes and epilepsy, conducted in over 50 countries worldwide. He was the lead researcher on the Cost Africa project between 2011 and 2016, which implemented on-the-job training of non-physician clinicians in Malawi and tested the supervision model for this CADA in Zambia. He was the international coordinator and lead researcher for the Horizon 2020 funded Surge Africa project, which successfully developed and delivered a capacity building intervention targeting non-specialist surgical providers at district hospitals in Malawi, Zambia and Tanzania. And currently he is the principal investigator on the Kids Surge project, scaling up non-specialist training model tested in Surge Africa to address the needs of surgical pediatric patients in rural Malawi. He's also co-PI of the MELD track project in Zambia, documenting the contribution of non-specialist surgical providers in rural hospitals. It's such a pleasure to have you join us, Kuba, and the head of our group, Professor Mike English, sends his apologies because he's away at the WHO this week. But we're really privileged to have you here, and having met Kuba, he's also, as well as being a really accomplished researcher, is also just a genuinely really lovely person as well. So over to you, Kuba. Thank you.
Thank you very much, Shelby. I'm equally excited to be invited to talk to you, and I am also very happy that I'm not talking to surgeons today, because sometimes I have a feeling that the issues that I'm going to be talking about are better understood by people who aren't trained in surgery, although it sounds a little bit bizarre, but let's see how it goes. So today I'd like to share the experience that we have here in our CSI based on the kind of over 10 years of continuous research. People call it global surgery, but I am not a big fan of that term, because as we know in global health and all the different global areas of work, it's kind of local and it's kind of very easy to pin down where the issues are. So I'd say it's the area that I define myself as a researcher working in is kind of a surgical systems research. So that's the kind of a main, the experience is based on the research that we've done in kind of researching surgical systems. A little bit of a background why access to surgery is important, because it's actually made it to the news, which is an interesting thing, because for a research topic to be broadcasted widely by news agencies, highlighting the importance of it is not a very common thing. So there were articles in BBC, but also other media agencies highlighting the fact that it's been established by the Lancet Commission for Global Surgery that nearly 5 billion people have now access to safe surgery. Also, looking at the kind of issues where surgery is not accessible, outcomes of patients are not optimal, let's say, particularly in sub-Saharan Africa, where twice as many die after surgery for many reasons. And thirdly, it's been recognized that looking at the health package that people should access, regardless of the place where they're born in, surgery must be integrated into the health package. And why is that? Because, and that is a very telling graph, which shows that surgical conditions per year kill more people than HIV, AIDS, tuberculosis and malaria combined, and issues to do with maternal and under 5 mortality. So the problem is really big. The problem is also kind of preventing countries from their economic and development growth. There is quite a lot of people that face catastrophic expenditures when it comes to, and even if surgery is accessible, even if a person wants to get or can go to a hospital and get surgery, for a lot of people there are systemic issues that prevent them, and even if they get to a hospital to get treated, they fall into something that we call the catastrophic health expenditures, which means they run into poverty. And to fix that, it's been estimated that nearly 150 million operations are needed to meet the current targets of what would be considered, safe access to safe surgery. And just to summarize the kind of a background peace, the surgery has been kind of proclaimed also by the WHO that surgery is an indivisible, indispensable part of health. Like I said, global surgery, as you look at the map on the screen, it's kind of local. The darker the color, access to surgery is more difficult. So it's not a surprise for any of us to see that the wealthier the country is, the lighter the shade of red is. That indicates that the kind of issues to do with global surgery are primarily within, let's say, the kind of a sub-Saharan part of Africa and also some parts of Asia. My work and the work of the team that I am part of focuses primarily on countries in sub-Saharan Africa, and we tend to say that we specialize in district level surgery. And why is that? It's just because people are there. If you look at the kind of a demographic situation in sub-Saharan Africa, the majority of people who live there are based in rural areas, and if they have any health problems, a district hospital, taking apart traditional healers and kind of an informal medical systems, from the kind of a formal perspective, the first port of call for them would be to go to a district hospitals to seek help for their health conditions. And again, it's not a big surprise to anyone working in this area to say that district hospitals do not have surgeons, because it's a global challenge to rural retention, and it's pretty much everywhere in the world that we can observe the same phenomenon, that people with high level skills, highly trained, they tend to concentrate in urban areas, and very few wish to work in rural areas for multiple reasons. In sub-Saharan Africa, the scale of that problem is enormous. They have still below 2,000 surgeons for the entire population of that part of Africa, which is estimated to be 320 million people, and that equates to half a surgeon per 400,000, which compared to Ireland, where I live, is 26 times less. And but surgery needs to happen. Surgery needs to be given to people who need surgery, and there are mitigation strategies that countries have adopted, formally or informally. And at district level, the bulk of work is provided by non-doctors, non-specialists, mainly non-physician clinicians or general medical doctors. But the caveat here is that even medical doctors, they have very limited surgical training, or actually no surgical training. So it's kind of an on-the-job training that they need to go through to provide the services that are needed for the people that from within their community. And the kind of a work that we've been doing, it's based on the kind of a principle that these people need training, they need supervision, and they need some sort of a professional development, because all of those things together are going to have a positive effect on the quality of care that they provide. And the response to that, as Shabi mentioned, I've been involved in 2 large-scale global surgery or surgical systems research projects. The first one was called Coast Africa, which stands for Clinical Officer Surgical Training in Africa, and that was done many years ago, to be honest. We finished in 2016, but that started in 2011. And that project aimed at developing a pre-service training for non-doctors in Malawi and Zambia. So the aim of the project was to demonstrate effectiveness, cost-effectiveness, safety, and feasibility of a model of training and supervision of non-physician clinicians to make surgery safe in district hospitals for Malawi and Zambia. So again, an important thing is that it's a pre-service training. So people go to that training before they actually start providing surgical care. And the second big project, the kind of a follow-up project from Coast Africa, was the Surge Africa project that we finished just about a year and a half ago. And Surge Africa stands for Scaling Up Safe Surgery for District and Rural Populations in Africa. And the difference between Coast Africa and Surge Africa is that we were no longer targeting non-physician clinicians in terms of upskilling the people and building their capacity to provide surgery, but we had a more kind of a team approach in that program, and whoever was surgically active was automatically becoming a target or the person to receive the intervention that this project developed. And I'll talk about that later on. Firstly, I'd like to take you through the Coast African project in a bit more detail, just to explain how it works. And demonstrate the kind of outcomes and talk a little bit about the issues that we've observed in developing those kind of interventions and sustainability of those interventions long term. So the aim, like as I mentioned, was to respond to surgical workforce crisis. Malawi and Zambia. In Malawi, there are still, I think the population is around 19 million. They have about 70 surgeons for the whole country. So there is a huge need to train people with surgical skills, and it takes quite a lot of time to train to fully train a surgical specialist. It's about 10 years or 12 years, depending on the context. But in terms of training non-physician clinicians, we developed a training that was only 3 years long. And so the first kind of objective of the project was to develop that training, secondly, to implement it, and thirdly, to evaluate it. And part of that training was also to kind of enable the knowledge that resides within central hospitals, that is the knowledge of the surgical expertise to kind of trickle down to district hospitals through in-person supervision and mentorship for the trainees undergoing the training. The details are that we've developed a BSc course in general surgery, which was eventually accredited through the University of Malawi, and it's still ongoing, by the way, for non-doctors to get the essential skills in surgical care and deliver those in district hospitals. It was a blended training comprising 6 months at central level, with kind of a basic biomedical sciences and all the theory that is kind of compressed into 6 months of intense learning, and followed up by 24 months, 2 years of in-service training. So the idea was to deploy pairs of clinical officers. Non-physician clinicians in Malawi are known as clinical officers. So deploy pairs of clinical officers to district hospitals and have the trainers come to them every 2 weeks to deliver the different kind of training modules. And the effectiveness of that training was evaluated through an RCT. We had 16 hospitals picked from across Malawi in the central and southern region. We randomized them in pairs, and we ended up having 8 intervention and 8 control hospitals. And I'll tell you a little bit about that. But firstly, I have a little video that explains the concepts and the principles of the Costa Africa training.
There are not enough surgeons in Malawi, and to train the right number of surgeons would take us a long time.
So we thought it made sense to try and upskill this cadre of clinical officers.
It saves transport, but it also saves money for the system as a whole.
The hospital became used to doing more surgery. The nurses were trained, the anesthesiologists were, empowered, and you really try to improve the quality of surgery in the district by the training. And so we proposed the idea of doing most of the training by mentorship within the district hospitals.
And it turned out well, because that's where hopefully they were going to work anyway. So if they trained in the environment that they were going to work, the result we felt would have been more ideal that way.
The implementation was visits to each training hospital every 2 weeks of a team from the central hospital with didactic materials, with provision of reading materials, and adherence to a well-developed curriculum.
Previously, I could do things without a scientific backup, without a scientific understanding, because I've seen somebody doing it.
So the basic science part is very important, and that's the first 6 months. And then after that, the mentorship part in the district hospitals involved a variety of modules.
Our level of profession has changed, because at that time, before the Costa Africa, it was up to diploma level. So there was no any kind of career progression at that particular time.
The most challenging thing is when you see a patient suffering, then maybe you're not very skilled to do that procedure. You take a patient to theater and then you see the patient dying. I think that's the most challenging thing that you're seeing.
When the Costa Africa came, it was like a bridge. It improved the quality surgical care of patients, and also it improved the referral system.
In many cases, there's no need even to go to a central hospital in the first place if you have a proper referral system. And in Europe, that's usual practice. Those referral patterns are being strengthened here. But unfortunately, not everybody is convinced that at the district level, people are able to perform surgery. It turned out that hernia surgery performed by clinical officers at district level, at least in Malawi, is as good as hernia surgery performed at central hospital level.
If it's a choice between no surgery being available to people in rural populations, or having somebody who's gone through a good training program and who is supervised, I believe it is an ethical, in fact, it's a duty to provide that service.
There will be no surgeons no specialist surgeons in the rural areas. So the alternative is to train people who can provide the surgical service, but safely. And this literature shows that if we train clinical officers, they will stay in the rural areas and they will provide the surgical service.
That's the training program explained, and some of the people who talked, they've already indicated the results that we've observed, and I'm going to take you through those as well. So as I mentioned, there was an RCT that we conducted just to see whether the deployment of surgically abled clinical officers makes a difference at the district hospital, and it does make a difference. If you look at this table, the bottom line is the overall change throughout the 2 years of the intervention between 2013 and 2015. We've seen that interventional hospitals, they improved their surgical productivity by 74%, and the control hospitals, the line of productivity remained practically flat. You know, there was not much of a difference. The first thing that we observe is that the volume of surgery goes up. You know, the second question that you're often being asked, and I am being, that's why I'm kind of, I mentioned that sometimes it's a difficult conversation to have with surgeons, because the issue of safety is always being brought up, and people who have never seen those kind of interventions that are kind of a task sharing in practice or task shifting in practice, they might say, "Oh, this is not safe. How can a non-surgeon provide safe surgical care?" I cannot say how does it look like globally, but in our research, there was supposed to be a table. I'm not sure if it's what's going on. Yeah, it's there. So we looked at wound infections, and we observed that there was no difference. CACO is Costa Africa Clinical Officer, so there were very few wound infections in general, but the difference between medical doctors, who were kind of a reference point for physician versus non-physician comparison, the difference was not statistically significant. So we concluded that kind of in terms of infections, clinical officers, they do not harm to patients compared to the alternative, which is kind of a physician-based surgery. We also looked at patient-reported outcomes, comparing outcomes of hernia operation between district hospitals and central hospitals. And we also observed that if you look at the p-value, that it's not the recovery trajectory. I didn't have time, I had a lot of things to say, so I needed to chop a lot of information to make it concise for this presentation. So if you're interested in looking at the detail of that, I'll send you the links to the papers. But we define a good outcome as no pain and good functionality versus no good outcome, which is some kind of impaired functionality and long-term pain. And there was no difference between district hospitals, with the assumption that district surgery is performed by non-physician clinicians and central level surgeries provided by specialty surgeons. So that was another argument to say surgery is relatively safe when it's done at district hospitals and it's done by non-specialist cadres. So that's South Africa, Costa Africa and Malawi. I'm going to briefly talk about the South Africa and Zambia, because the situation when we started the project was slightly different. Zambia was a little bit more advanced in terms of their training programs, and they already had an existing non-doctor, non-physician clinician surgical training that was called medical licentiate, ML. However, it was at the level of diploma, so there was a lot of frustration among the trainees to say, look, we are studying hard, working hard, but there is no incentive for us to pursue that career. So one of the aims of Costa Africa was to upgrade that existing training to BSc, and that is what we achieved. And also we've changed a little bit the training to add the elements that we've had tested in Malawi, which is the 2 years of supervision and the visits. So the mode of the training was also similar to the one in Malawi. And the results were slightly different because the healthcare system in Zambia, I don't have time to take you through all the different details, but there are way more hospitals in Zambia and far less surgical or all kind of health workers. So hospitals are in many cases empty, both in terms of staff and in terms of patients. The productivity is a black box to explore. But going back to the topic, if you look at, for instance, the hospital, the first hospital on the list, Choma, it has 1 ML, which was our trainee. She was a female, very motivated girl. 3 other surgical providers, visiting surgeons are people who are in full-time, and 12 medical doctors who are full-time in that hospital. And then if you look at the surgical procedures, the percentage of surgical procedures performed by these people. So if you look at the 12 medical doctors, they did 75% of cesarean sections, while a single medical licentiate did nearly the all remaining 25%. So one person did 25% of surgery versus, let's say, 12 plus 3, 15 people doing the other 75. So her contribution to surgical care was huge. Also, index procedures. In our case, we picked hysterectomy, salpingectomy, laparotomy, and hernia and hydrocele repair as a kind of a proxy for general surgical care. That single ML, her contribution was also very big because she did, again, around 25% of all those cases single-handed versus the other 75% of cases done by the other 3 non-full-time or visiting specialists and the other 12 doctors. So, and that was not an isolated case. If you look at Mamba, for instance, we had 2 boys there, 2 very good guys working there, 2 MLs, and they did, let's say, 40% of cesarean sections and nearly 40% of all the index cases. So, you know, again, having a trained ML to a BSc level in a district hospital makes a big difference for the whole system. The numbers also went up. I forgot to include that slide, but there was also a positive change in terms of the volume of surgery. The second thing to kind of highlight is just a kind of a crude number, average number of cases per cadre per year. So if you look at the number of the medical doctors practicing in Zambia, they had, let's say, 23 cases of cesarean sections per year versus 30 cases of cesarean sections for the MLs. So if you look for every hospital that is on the list, for instance, I don't know, let's say St. Margaret, the one at the bottom, a medical doctor practicing in that hospital would do 8 cesarean sections in a year, which is not a lot, versus the ML who would do 45. And you can also, what I referred to at the beginning of this part of the presentation about Zambia, that the productivity level in those hospitals is not very high. So there is a lot of research to be done to fix that, but that's for a separate talk. Kind of wrapping up the findings from Zambia. We also identified that, you know, in Zambia they played a very big role, a crucial role in delivering surgical services at district level. And they provided elective and emergency surgery that would have not been available otherwise. They worked hand in hand. They worked on occasions very well with medical doctors, giving them introduction to surgery, because the medical licentiate, they had this 2.5 or 3 years of surgical training provided by the Costa Africa program. And medical doctors in Zambia, they didn't have any exposure to hands-on surgery. They were more when they're undergoing the medical training, the role in the operating theater as they were doing their rotations was more of an observer than the actual operator. But in some cases, we've seen that MLs face professional recognition problems, and due to that, there were tensions between them and the other cadres, such as medical officers, that impacted negatively their ability to utilize the surgical skills. We've observed that in certain hospitals, the medical doctors working there, they didn't know anything about the ML profession. They would say, look, who is that guy? Why is he, entering the surgical theater? And I am the doctor here, so I'm supposed to be doing those cases, not that person. So we've observed that kind of a professional rivalry to a certain degree. And, we did a study basically on that, just to explore how does it look like and what are the barriers and enablers for ML to function. And I'm still involved in a project, so I'll talk about that later on. But we also, so that was the Costa Africa project was ending in 2016. So around 2015, we started to ask ourselves a question: is it going to work long term? There was a 3 million euro invested from European taxpayers' money into that program, so it was a pretty decent investment, and we we wonder, is it going to last? You know, we were very happy with the results. We had the papers published, and you know, everything looked very promising. But we wanted to explore what is going to happen if once the intervention starts to live its own life. So we, at the end of the program, that was December 2015, we conducted qualitative interviews with the graduates of the Costa Africa program, and we repeated similar interviews 5 years later in 2019. So the objective of that, kind of the idea behind those particular study was to look at career aspirations in the first place, just shortly before people were about to graduate, and then their career plans following the graduations. And the second set of interviews 5 years later was going to kind of attract them across the different facilities in Malawi and see where they ended practicing, or where they meant to be, which was at the district level, or did they change their career trajectories and started doing other jobs. And the results were kind of a little bit unexpected to a degree, but also not the big, not very surprising, because in 2015, 11 of the clinical officers expressed the will to practice at district level. You know, following graduations, they wanted to go back to their families, they wanted to go back to their communities, and that was their wish. But in 2019, we only found 6 to be practicing at district level, and we also observed that the ones who weren't, you know, who did not have exposure to district level surgery prior to their training were less likely to take up employment at district level following the graduation. And the reasons behind that were firstly to do with money, because the salary of a clinical officer with BSc in Malawi, who spends a lot of time, and these hospitals are very busy, they do nearly 500 cases a year with a single theater. It's around, I don't know, at that point was $400 a month. You can imagine that is not a lot of money, and they were very demotivated receiving those kind of salaries with that workload. And they also said that in the NGO sector, the pay is quite different compared to the government, and the NGO sector was more attractive to them. So a lot of them were already in the NGO sector or were about to transition and change the career trajectory and start doing something that is not really related to surgery, but would give them better income. Also, another thing that that they said is that surgery itself, compared to other professions, is not very well marketed, and there are very few opportunities for additional income. So people said that, for instance, if you do pediatrics, or if you do obs and gynae, there is a lot of workshops, there is a lot of training opportunities, a lot of things that you can generate additional income from. And surgery itself, because it's not a priority for the global donors, such as, for instance, pediatrics is, or maternal health, there are no workshops, there are no trainings, there are no income generating opportunities. So that was also for them demotivating to say, look, I am here in this theater doing all this hard work, and I am just getting $400, while my friends, you know, they are the HIV coordinators, TB coordinators, and they go from workshop to workshop, receive allowances, and they're living a happy life at the district. So that was one of the things that people complained about. Another thing that they say, which is also, I don't think is a big surprise for you working in the area, is there was no advancement beyond the current level. They wanted to look at opportunities within the surgical field. And they say that they felt forced to divert from surgery, because if they wanted to progress as surgeons, you know, the BSc level was the highest possible degree for non-doctors in Malawi, so they felt stuck in the area. And the other thing was that there was no promotion, and the government did not recognize them as different cadre compared to the regular clinical officers. So for them, it was a very bitter sensation to say we've done all the hard work, we went back to school, we did 3 years of studies, and we are back called clinical officers, which doesn't feel just. So they also wanted to kind of express that kind of a dissatisfaction. So that's where this kind of a story of Costa Africa ends. And in response to some of the problems that we've identified, you know, the professional isolations, the tensions between medical doctors, you know, lack of career progression, lack of opportunities to train, and all the different things, we came up with another project, which was started just back to back with Costa Africa, South Africa, which was in-service training implemented in Malawi, Zambia, and Tanzania that aimed at not just one non-doctor, non-physician clinician that was undergoing the BSc training, but the difference was that the whole team was targeted. So the intervention was not a surgeon going to train a surgical provider, but a surgical team, which was included anesthesia specialists, operating theater specialists, ops and gynae specialists, and in some cases orthopedic surgeons as well, to go to a district hospital and train the whole team, giving them additional skills and enabling them to do a wider range of surgical procedures. And a kind of a principle of behind the Surg Africa concept was that whoever holds a surgical knife is a training material that can receive that intervention and improve their skills. And I would like to highlight why it's that, because if you look at some hospital, this is our baseline data from 2016, I think, or 17. So we identified across different hospitals in Malawi that the basic skill, which is the cesarean section, the surgical procedure, is, quite a lot of people can do it. If you look at Cholo, the last hospital, 31 people could do out of the existing staff, which was pretty much every clinical officer in that hospital could do a cesarean section. However, when you look at elective hernia, only 3 of them could do an elective hernia. So the idea was to take the ones out of the 31 who have that basic understanding of surgery and who have interest in surgical care and who are willing to be trained, to give them the opportunity to be trained by a surgical specialist together with their anesthesia and nursing team on how to perform those operations safely. The same observation was the same kind of a situation was found across Malawi, across Zambia and Tanzania. In Tanzania, if you look at, for instance, the first hospital, Meru, 24 hospitals could do a cesarean section at the time, while only 1 person could do elective hernia. So, the principle was the same. Let's take these 24 and let's try to give them an opportunity to upgrade their skills, upskill themselves. The other objective. So first objective was to improve people's skills. Second objective was to improve surgical referrals. As you might remember from the video, one of the issues that people mentioned was the kind of the problem with surgical referrals, and we did a study around 2015-16 to explore what are the current trends in surgical care and in surgical referrals in Malawi. We collected two years of data, slightly above 1,300 cases. Majority of the referrals were male, and a lot of them were pediatric cases. And the idea that we wanted to look, the research question was, what are the referral patterns and are there any inefficiencies in the referral process? So again, there is a whole paper published about that with all the methodological details that I don't have much time to talk about today, but we picked 6 indicators of quality of surgical referrals, and we identified across them that in 4 hospitals there were major inefficiencies. So the red color indicates that there is a big problem. If you look at inadequate investigation in 80% of cases, incomplete patient vital signs in 85% of cases, referred to Queen Elizabeth Hospital in Blantyre. 2 out of 3 cases, they received inadequate initial treatment and stabilization. In terms of the diagnosis, the situation was slightly better, but still a lot of work to improve that. And the main thing that we observed, and the main kind of a driver for follow-up intervention, was that most of the cases, 82%, came into Queens without any prior announcement from the district hospital. So the ambulance would come and here you are with a new case referred from a district hospitals. So we came up with an idea, very simple. Again, that is an interesting story, because initially we wanted to develop an app for that, to streamline the referrals and enable people to talk to each other, kind of improve the communication system between district and certain hospitals. But there was an app that was already existing, and people, I'm talking to colleagues in Malawi, they told me, look, Kuba, there is a WhatsApp group for everything. And I thought, look, why don't we create a WhatsApp group for surgery? And so we did. And it was a kind of the principle behind it was a managed clinical network. There was a controlled access to that group. Not everyone could be enrolled. There was certain criteria to be part of that group. There was a patient controlling the traffic and kind of managing it. And after the first 8 months of that group, we did a study which again there is a paper about that. How did it work in practice? And we observed that 2 consultants on average gave advice per case. For every second case, there was a picture, which also helped with assessment. Nearly 80% of cases received the first response within less than an hour, and also nearly 70% of the cases were resolved within less than an hour, which was a big gain for the referral system in Malawi, because the specialist knowledge was transferred in real time to district hospitals in a safe way, because the managed clinical network was truly managed. And this is the interesting bit about that, that pie chart, because you remember when I was talking about the study that we did in 2016, looking at the referral system in Malawi, 1/3 of referrals were, maybe I forgot to mention when I showed the slide, that the one in 3 referrals was really not supposed to be referred. And in this study, we found that through the kind of a managed clinical network, the advice from a consultant on the cases posted in 33% of cases was not to refer. So we are able to kind of limit the number of inappropriate referrals. And currently, I'm still part of that WhatsApp. That WhatsApp group is still living its own life, and it's doing quite well. And we are just about to finish a study, kind of 5 years into this WhatsApp group, to see what are the differences. And there is nearly 400 participants. We have pretty much every hospital in the southern region of Malawi in that group. What is the crucial thing is that every single referral that comes to Queens is pre-announced on that group, and it receives a consultation, receives a go-ahead from the consulting team. So there is if we were to look at the 6 indicators, a lot of things have changed, but we need evidence to demonstrate that. And just to kind of take you through the whole story of that WhatsApp group, again, there is a little video, which is pretty much all I had for today, but I hope you're going to enjoy it.
We tried to come up with a way of connecting the DC hospitals with the consultants at Queen Elizabeth Central Hospital. So WhatsApp group was the idea that we came up with.
I think it's being very effective at that, because it's kind of instant consultations. People with questions are getting feedback from a specialist almost immediately.
We post even the pictures, and the consultants do see the pictures, and they can advise to say, well, proceed to this side, so that you are able to reach the problem.
You give feedback immediately, you say, deal with it there, do this, do that, or, do these investigations and call us, or send the patient up, or sometimes don't send the patient up.
We find it very useful because we notify them in advance so that they should get prepared.
You need to discuss the cases even before you refer them. They say, oh, well, Mr. Malunga, before you refer the patient, do A, B, C, D, E, because this patient has to arrive in Queens once in a safe condition.
It's pretty helpful in terms of giving them advice. For example, if it's something that they can do at the district hospital, at least you'll be able to give them advice on what they need to do for the patient before they refer, or at least as they refer.
When we send the patients, we get even feedback right away on the WhatsApp forum.
I love the feedback and even the teaching itself, because medicine is dynamic. Each and every day you need to learn.
We have got 10 DC hospitals, and in terms of membership, individuals, we have got 100 individuals, almost 100 individuals in the group. They have access to about 14 consultants. The good thing about the WhatsApp group is that once they post a case on the group, 1, 2 or more consultants will contribute on the case, which creates that access to many consultants at once.
We're not reaching only to one person, so you reach out to quite a number of clinicians. So as much as I may advise one person to prepare a patient in a certain way on a specific patient, I'm sure somebody else is also learning from the same group.
The best thing is that not only that we are given feedback, but also we are learning.
There was quite a big gap between us and them. But now the WhatsApp group, basically, we've come like a family. We can interact, we can communicate, and they're not afraid to ask for medical opinions, surgical opinions.
It's a no-cost thing. It just takes people's time. There's no money invested in it, so there's no reason for it not to continue.
Through Surge Africa, these are happening, and that's what Ministry of Health is supposed to do anyway, and the central hospital is supposed to do, and Surge Africa is just helping, coming in the right direction at the right time.
Yeah, so just to summarize the talk today, there was a kind of a progression between the Costa Africa program, then into South Africa, which is a formal training, BSc level, then South Africa, which was an in-service training and supervision program. Also, as part of that, we've improved the referral system through, the WhatsApp group that we just explained, and this is all kind of the importance of the intervention. If I can kind of say that this is all one big intervention at district level in Malawi, Zambia, and Tanzania. In Malawi, in particular, is that surgery in those hospitals is done by non-specialists, and these people need some sort of help to, first of all, to remain in those facilities, to be appreciated about the work that they do, to be up to date with what is the latest in the discipline, to kind of remain motivated in all the different and all the different other things that are kind of keeping them happy. What their daily job is about. And currently, we are taking we are using the South Africa model in a project that it's called the Kid Search Project. As I mentioned, 1/3 of referrals to Queens at the time when we did the study were pediatric cases. So we are trying to see how much of pediatric surgery can we teach through in-service training, through sending pediatric specialists to district hospitals in Malawi and skilling them in the same way that South Africa did in general surgery. And I'm also involved in a MELTRAC study, which is the medical licensing kind of a follow-up, similar study to the one that we did in Malawi, which was called Why Do They Leave? Right now, I hope the title is not going to be Why Do They Leave for Zambia, but we are yet to see the evidence. But we are also tracking people, 10 years after the training, or at this point, it's kind of 10 years after they started the Costa Africa training, and the last arrow, which kind of leads towards infinity. We're kind of full of ideas on how to help those cadres to thrive in the roles, but it's yet to be seen what kind of other research questions we are going to have. And this is my last slide, and thank you very much for your attention.